Okay, Mr. Chairman, always pleasure to be here, so thank you for the invitation, especially thanks to Artur. Actually, I'm here for the first time. Short trek to Krakow, but I'm here for the time, nevertheless. My role is to present real-world effectiveness and safety of ixazomib use in multiple myeloma. This is my agenda, and first I just emphasize the role of real-world evidence data. I think it's increasing role and importance of such data. I think it's understandable. Whenever we see the improvement based on the randomized trial, we want to be confident that it's translated to real world. So that's really a position of real world evidence data. And we know it's sometimes quite tricky. From several analyses, we know that almost half of our patients from real world are not eligible for trials in multiple myeloma because the inclusion and exclusion criteria are so strict and rigorous. So, and we have different real-world evidence data sources which are listed on your right side of slide, and could be, of course, registries, it could be electronic health records, it could be expanded access programs and others. And in Czech Republic, we are more than happy that our registry of monoclonal gammopathy has already 15 years. And you can see number of patients enrolled to this registry, more than 5,000 with MGUS, close to 10,000 with myeloma, and a limited number for smoldering amyloidosis and Waldenström macroglobulinemia. So we can use this registry for different analyses. As example, I'm using this changing in treatment pattern during the period of time, so comparison use of drug in 2016 and the changes seen in 2020 plus. And I always mention the robust start of daratumumab RD regimen in second line in 2020 in Czech Republic. And I think it's unique that one drug, lenalidomide, it's widespread across through all treatment lines, which is really quite unique. So that's just example. We will talk about ixazomib. So I just remind you with original tourmaline MM1 study, based on which this triplet ixa-RD was registered. Okay, it was for patients with up to 3 prior therapy. Experimental ixazomib was added to RD, so RD serves as control arm, and it's chronically known data, clearly statistically positive outcome of the trials, progression-free survival experimental arm, 20.6 months. We know, and I will not discuss and mention it later, that safety profile of this combination is excellent, and compliance of patients is also excellent. Nevertheless, this data, this trial was planned 12 years ago, and major publication is already 7 years old. So as you saw, the treatment pattern change, and the progress and development in myeloma treatment is so rapid. So when we discussed the window for allogeneic transplantation in first presentation, to me is almost closed indication for allogeneic transplantation myeloma. So also closing the window for this triplet, ixa-RD, especially in the best optimal conditions, which is first and second relapse. Why? Because we have many countries now when all backbone RD triplets are available, And definitely the first choice is usually Dara-RD because the benefit for patients is excellent and much better for others, despite its indirect comparison in this slide. So when we use the Dara-RD in first relapse, it's no chance to use ixazomib in second relapse. So probably if we postpone to fourth and plus relapse, then we know that it's already limited efficacy for any triplets in that setting. And for many countries, we already know that Dara-RD moved to first-line treatment, or we are using VRD as first line. So it's scientifically good to use ixazomib in first lap, and then we have other treatment very effective. So it's not closed window, but the window's optimal scenario for this regimen is closing now. So now some data from real world about ixazomib. We have privilege to participate on patient AIDS program from the beginning. For our first publication, joined forces with colleague from Greece and the UK, was for the first time presented in 2018 during the ASH. And then we analyzed data several times. Usually the progression-free survival was very similar to original trial at that time. So I mentioned just one result published by us when we compared ixazomib versus RD in a real-world setting in Czech Republic. And as you can see, progression-free survival median was 17.5 for all group. But if we selected just patients fulfill criteria for original trial, Tourmaline MM1, that was impressive 23 months. So the data from real world were really excellent. And opposite to original trial, we also could demonstrate the benefit of overall survival. As you can see, 37, close to 37 months versus 26 months in RD group. So that was our data, and I always mention also our collaboration with Insight registry driven by Takeda. We merged data together, analyzed 263 patients, and the results were very, again, similar to original Tourmaline MM1 trial. And I just mentioned here that for those with advanced disease, the efficacy of any triplet, including ixazomib, is already limited. That's what we know. So finally, we just discussing what is the optimal characteristic favoring the use of ixazomib in a relapse setting. So definitely patients with slow relapse. This is not combination for aggressive disease. Definitely unfit younger or frail elderly patients. I think the distance matter. Patients definitely can benefit from a fully oral regimen, especially, for instance, in COVID epidemiologic situation. Patients could visit us every other month even, so that was really good. So, and also sometimes we using strategy switching from very intensive triplets to less intensive triplets, and again, this is oral, very convenient regimen for our patients. So finally, I will present data comparing triplets in real world, but already using data from the year 2020 plus. So we analyze from all available patients finally 549 patients and compare Dara-RD, ixazomib, and KRD using standard statistic methods. This is the just data about number of previous lines. It was no clear difference. We also focus on extramedullary disease, We also focus on high risk, low role cytogenetic risk, or standard risk, which was slightly higher for DARA-RD than ixazomib. Here you can treatment response. I think no surprise that the highest response is seen in DARA or carfilzomib RD group. And the most important are overall survival data, not reached for DARA-RD yet, 62% in 3 years. For IXA and KRD, very similar data, 41 months. If you're talking about progression-free survival in real-world data in Czech, it's not so good for DARA-RD as from original trial, limited for ixazomib and KRD. So you already seen this slide, which compared randomized trial, experimental arm versus RD, and that now similar slide, experimental arm versus real world in Czech. So you can see the difference, 7 months difference for ixazomib, 12-month difference for carfilzomib, and even 21 months difference for DARA-RD in our hands. And benefit seen even for overall survival for IXA, not meaningful for IXA and carfilzomib, but good for Pollux. And this is also data about duration of treatment, which is relevant to shorter progression. So finally, we just discussing inside why our data was so good in the first cohort and now are so not good. I will not show you data. I hope it will be seen during this ASH. If it will be accepted, I think it will be. I do believe it will be. But definitely, it actually has nothing to do with the treatment lines. But in 2016, there was no other triplet available. So the best patients receiving ixazomib, because it was only triplet available. Now, this is completely different scenario and different patients. So that's probably explanation why the data are not so good now, because it's completely different population of our patients. So I finish with conclusion. I think the real-world data has been recognized even by regulatory bodies such as FDA or EMA. Approximately 40% of our patients from real world are not ineligible for clinical trials. Several studies documented the effectiveness of ixazomib in real-world routine clinical practice, but benefit for patients treated with ixazomib is highest in first and second relapse, and it's very difficult to find such patient now if the other triplets and more effective therapy are available currently. And our data from our registry demonstrate a lower progression-free survival outcome of triplets generally in the real world, as well as shortened duration of treatment if compared to registration trial. And I stop here and thank you for attention.
Thank you very much for this presentation, which is now open for discussion.
So I have a question, how is the situation with ixazomib in Poland?
It was not good in the past, but now it's better because it's possible to use it in second line at the moment. In the past it was on the third line, and we can use it as a second line, but of course, as you know, it's not only regimen, and to be honest, I don't use so much in my clinic at the moment. In the past, I have some patients, but at the moment, not so many, to be honest.
I would add that, of course, from, let's say, administrative point of view, it would be the ixazomib is the most attractive because it's oral. So patients who cannot really travel to some transplant or hematology centers, I mean, even in like Warsaw, some of the patients in Mazovian voivodeships where Warsaw is located, so they have 120 kilometers travel to the center. So for them, it would be, of course, the great benefit if we would be able to put them totally on oral treatment, and they would then travel to the hematology centers once a month. So that is right now the limitation is mainly with high-risk patients with cytogenetic abnormalities.
Yeah, I agree that for some patients, you know, they are requesting fully oral regimen, so that's good option for them. Please, Hartmut.
Roman, excellent data. And in my view, it's very important to have these data because many of the trials comparing 2 or 3 drugs, comparing 2 versus 3. And you have an overview in Czech Republic about how is the use of 3 drug combinations, and to know that it's very, very important. And also, I'm really happy to see that you have another situation. You have now more 3 combo options in Czech, and this is realistic that change the use of IXA.
Yeah. Thanks.
Roman, very, very nice data. I was wondering how come DRD was so bad in the real world. It was 20-something months of PFS, right?
Yeah, we were slightly disappointed with the outcome, true. We are still undergoing analysis. We will present data on ASH. But, you know, it may be some learning curve, some selection of patients. We, you know. More high-risk patients. Yeah. Actually, no, it was not more, you know, DARA-RD and IXA-RD, the proportion of high-risk patients is close to 40%. So it was higher than in others, but still, you know, slightly disappointed, yeah.
Yeah, we have seen the first data from the French group also analyzing VAD in daily practice, and the data terrible because the toxicity it's very high. And as we have seen in amyloidosis, the toxicity also in patients with relapsed multiple myeloma over the age of 70, it's higher than expected. Therefore, be safe if you want to treat a patient with VAD. On the other hand, it's an effective treatment, and for patients around 70 years fit, it's a good option, and you can add DARA, it's also a good option.
Are there any other questions or remarks? So if not, so thank you very much.